Well, hi, everybody. Welcome back to the podcast. We're joined today, returning guest, Arnaud Aurelio. He was a guest in episode 403 back in 2021. He's been working with lean management since 1995. That's when I started. There's a lot of parallels to our stories if you want to go back and listen to that episode 403. But he's worked for the last 15 years as a trainer, coach, and consultant in healthcare. He's the owner of his firm, The Lean Mentor. He helps people who want to learn how to improve healthcare. So his first book was titled Lean Thinking for Emerging Healthcare Leaders. And he has a new book coming out titled Lean Thinking in Healthcare. So we're going to be talking about that today. Arnaud, thank you for coming back on the podcast. How are you?
Yeah, I'm fine. Thank you. Thank you so much for having me back. It's always good to have conversations with colleagues, especially because since our paths are so similar without us being aware of it for a long time.
Right.
Thank you so much for having me back.
Yeah, well, it's great to talk to you again. Arnaud's website is leanthinkinginhealthcare.com, and I'll put links in the show notes to the past episode and the books. And again, congratulations on the book. So that's going to be sort of, I think, part of how we structure the conversation here today. Arnaud, you introduced yourself and told your story last time, but with the book, you talk about learning how to improve. And how would you summarize, without telling your whole career story, like learning how to improve, learning how to learn how to improve? Tell us about that part of your journey.
Yeah, so as an engineer, I think I got this intrinsic drive to make things better. As a perfectionist, I had a tendency to think that things needed to be better. So maybe that accelerated things a bit. And then when I started my career in the automotive industry, I was almost confronted as a manager with the fact that performance improvement was your daily work.
Mm-hmm.
But maybe not how we think about it currently. It was the performance needed to be what they said it needed to be. And if it wasn't, then you had some kind of conflict. And the conflict would be around maybe your line has stopped and then your boss wants it to run and the operator wants her problem to be solved and to be recognized for the problem.
Mm-hmm.
So I learned early about improvement that it has a lot to do with how we treat people and how we perceive problems.
Mm-hmm.
Recently, I got a post on LinkedIn where somebody replied with, "Yeah, you shouldn't use the word problem."
Yeah.
Because that has a negative connotation. And so I was taught early on that it's maybe better not to have problems. When you're in an organization where hierarchy is the method. And what I mean by that is that when your boss is telling you what to do because he's the boss, and that's the way to go about improvement or at least getting things back on track. Well, I perceive that as, didn't work for me. And later on, I became a lean consultant. And then I was handed a completely the opposite almost way of going about solving problems. And it was because what we did as consultants had nothing really to do with consultancy. We went to the shop floor, to the mostly factories, and we were starting conversations with the operators about what do you think the problems are? And what do you think caused them? And what do you think we might do about them? And then I figured out, wow, these people know the answer to these questions.
Right.
So leadership, instead of using the hierarchy, you can better use the hierarchy of competence. And that means that you best start your problem solving with the people who are doing the work and know the problems best. So that was the first transition I made. And then after that, the more I did it, the more I find out this is not just a method or a way to solve problems. There's a system behind it. And this system consists of a set of principles. And if you use them in concert, I don't know if you can say that in English, but then you get these wonderful results while making everybody happy. So all stakeholders are recognized for their needs. Like the customers are recognized for their needs, and your management is recognized for what they need, and operators as well as maybe suppliers or even owners of companies. They're all in it equally. And when I found that out, of course, it was a small step to finding out it had nothing to do with factories. Although I was trained in a factory, and all the books I read and all the methods I learned, like TPM and Lean, etc., came from factories. It had to do with people who wanted to do things for other people. And that brought me to the path of going into the office, which is a completely different environment. And their problem solving is even more difficult because in the office, there is no system for performance. So like in the factory, we always knew what the quality was, how many products we made, etc. But when I came in HR or but even in finance, what was their process? And
what are their measures, right?
What are their measures what are they measuring on? How do we know they're doing the right things, etc.? So we developed as all kind of tools to visualize problems in an office setting. And then, of course, like most people will experience, there's enormous amounts of waste in the office, way more than in factories. And this is because in factories, at least you can see when there's waste. You can see piles of stuff, or you can see a bin with rejected products. But in the office, there's no way of knowing whether it's excellent or not, and whether it's productive or not. And from the office, it became easier to maybe help organizations who had nothing to do with production, or at least not in the factory sense of the word. And because I at the time I have 3 sons, so I visited the hospital from time to time. So I got this personal experience of hospitals, and I knew about a system to improve problems. And then I found that these hospitals, it looked like they didn't have that system. But it appeared that they had a lot of problems, at least in my eyes. And I think that's when I took the next step in process improvement, like focusing on a sector where I felt the need is high. There's maybe a lack of awareness of the fact that these problems are there and that they can be solved. So I was compelled maybe even to change my career focus. And from that time, I made it my mission to build what I called at the time world-class healthcare. And so that's so improvement became from doing things to solve problems in a factory, being my philosophy of how I think we should go about making the world better. And in my case, hospitals or healthcare institutions.
I mean, in hospitals, in a lot of ways, you can see the waste very clearly, the way you might see waste in a factory. You can see patients literally waiting for care. You can see the physical motion of the people doing work, and the waste that's driving wasted motion that delays patient care and leads to the extra waiting time. And then, like in an office setting, a lot of the waste in healthcare then is somewhat hidden because of it's more administrative in nature. I was wondering if you could tell us a little bit more about that, and helping people see the waste, and then the leap. Sometimes people can see the waste, but they think the problem isn't solvable. Like how?
Yeah, exactly.
How do you help through that?
Yeah, that's I recognize both. So, as a patient or following the patients, it's easy to see waste. But it doesn't mean that the caretakers know how to see waste, because their eyes are not on the patient flow.
Mm-hmm.
Their eyes are doing their work.
Right.
And because they're forced to do their individual work extremely efficient, and whether that's truly efficient or not, we can talk about that later. But so there's a lot of, I think you could call that resource focus and resource efficiency. So we need as least amount of doctors and nurses to do the job as we can get away with sometimes, maybe even. And but what we forget, or at least what I see, is that if you would make a detailed analysis of what a nurse or a physician is doing throughout the day, and detailed, I mean, let's say every 5 minutes, I found that if you would then categorize that work in 3 buckets, and one bucket is doing work that is actually needed to help patients. That could be work that is necessary under current conditions. That's maybe it's you need to do it by law, or maybe the health insurance company requires you to do some registration, or all those kind of things. And then there's a bucket waste. And waste means that you're walking about, or you're searching for things, or maybe you have to correct something because it didn't go well the first time. And then it's interestingly, I found that it's 1/3, 1/3, 1/3.
Yeah.
So that means that so my mission could be, I think that for healthcare, we could say we can double productivity without hiring anybody.
And without working twice as hard.
Without working twice as hard. Yes, exactly. So, because if you would cut the necessary under current conditions, but not adding value time in half, and you would cut waste in half, then still you have time to do those things, because I don't think we help anybody to say that it need to be perfect, because there's always waste and there's always things to do because the legislators want us to. I mean, I have a business of my own. I need to tell the IRS about my value-added tax, etc. So yes, it's always like that, but it doesn't need to be as much as it is currently.
Yeah.
So within these silos of so-called resource efficiency, we can still do twice as much with way less energy, because why nurses and doctors have to work so hard is because this administrative work and this wasteful work, your body knows when he does that. So it's way more frustrating. It costs way more energy. If you're working with a patient and you do what you love, this will give you energy. Right. So it will be way more easier if you could do that all day instead of filling in forms, etc.
Yeah. Well, that there's a phrase for those who are just listening to the audio podcast. They won't see the video. There's a flip chart behind Arno, and there's a phrase there that seems to encapsulate what you're talking about there, and an important goal for healthcare: more time for better healthcare. We look at that theme. Releasing time to care, I think, was the name of a program in the NHS England at one point. There's another similar program, Transforming Care at the Bedside. But I think that phrase, releasing time to care, more time for better healthcare, that's a very important goal. It's a very positive framing. And I'm thinking back to the history. I think this goes back at least 15 years ago. I think that program in NHS England was initially called the Productive Ward, and the people in the wards felt insulted. And it's not a matter of blaming the ward for being unproductive. They're doing the best they can. They're working too hard. So I think a phrase like releasing time to care, that's a better
word. Yes, yes. It's interesting that the number one most important goal for healthcare, increasing productivity, is one that has so much negative connotation, because that it was very difficult to talk about productivity. Whereas if you would call productivity, is to me, it's just the amount of value added work you do compared to the resources you put in.
Sure.
So, but because productivity is for so long measured by how much time do you work, people think, I work all day and I work overtime, so I can't be more productive.
Sure. Right.
And that's a difficult thing to do.
Yeah. And there's a lesson going back to Taiichi Ohno, motion does not equal value, or being,
exactly. Yeah.
And people conflate the two. And these are dirty words. You mentioned earlier problem and productivity. Because there's quite often a lot of blaming and shaming associated with those words, where in some cultures, like a Toyota culture, the word problem is pretty neutral. Like the problem exists. It's like pointing to a wrench. It exists. Let's do something about it.
Yeah.
We don't have the same emotional stress that's created.
Yeah. They might even think that's a positive word, because no problem is a problem, is what Taiichi Ohno said.
Right.
And I think that's true. If you don't know what your problems are, how are you going to improve? So, but then that can only be true if you get the help you need to actually solve the problems, because otherwise you could just get frustrated.
Right.
I mean, sometimes we do these exercises to have people see the waste in their department, and sometimes they make very long lists, and that's not necessarily what makes them happy, because some people like me, I can't unsee it.
Sure.
So once I saw it, then I keep, it will be on my focus.
Yeah.
So. Yeah, and what's interesting about more time for better healthcare is also that there's a lot of research, at least in the Netherlands. I'm not sure if it's international research, but it could be, that if a family physician or general practitioner would spend 15 minutes with a patient instead of 10, it saves a huge amount of people be sent to the hospital. Because then you can get a true anamnesis and a good true diagnosis of what's going on with this person, what's his context, what's happening at home. And then that normally is enough to find out what can be done without having a specialist look at it.
Right. Yeah, so, that sounds like another example of the difference between resource efficiency and system effectiveness, or system efficiency. Yeah. The American system is so disjointed; it's difficult to think systemically. That might be easier in some other settings, but it's a bit of a recap. Not to dive into this too much, but my understanding of the Dutch system is that it's more similar to the US system than it would be to the NHS England system, that you have private insurers that are nonprofit and private healthcare delivery organizations. Is that a fair summary?
Yeah, but we haven't. So what's similar is we use the health insurance companies as the payers. And then we have the patients who pay a premium to the healthcare insurance organization, and they make contracts with the hospitals. And then these hospitals, they report how much care they're providing, and then they get paid. At least, so that's how it should work. But these health insurance are all non-profit, so we don't have health insurance who represent a business.
Right.
I think you have in some cases.
People get insurance independently as opposed to being an employer benefit, right?
Yes, it's a private, and and everybody has insurance in the Netherlands. You're even obliged by law to have an insurance, to have health insurance, and then there's a basic package which is defined by the government, and they say, okay, these treatments and these kind of help is compensated, and and you can have additional packages if you want to have extra.
Right.
But these are by choice. So, and what so the good part of, and what is very different in the Netherlands is we have a very solid first line, we call it. So the family physicians or the general practitioners, these are at no cost, so anybody can go anywhere. They don't have to pay a contribution of some kind. And I think that it's about 95% of the curative care is done by these family physicians, and only in 5% of the cases people are sent to the hospital. So this is where our system is fairly cheap.
Yeah,
or lower cost than particularly than the United States.
Yeah, and then is there a capacity shortage at some point, or is the system designed in a way where more physicians are encouraged to become general practitioners or primary care, so that you can go get that care without waiting a long time for appointments?
No. So the problem is that these health insurers, they make contracts with all care providers, and they try to squeeze all of them. So, and this is where the system is going wrong, because the health insurance companies are saying they select on quality and cost, but because they are health insurance, they can't judge quality. So what they do is they make all these rules and all these regulation, all this administration, so all this bureaucracy, so care providers can prove that they do the right things, that their invoices are legitimate, etc. But if you ask somebody who's doing the work to be accountable for that work to somebody who doesn't understand the work, that means that it's all built on distrust. And that means that the bureaucracy is always increasing.
Yeah.
Because it's never enough. There's always a reason why they think it's not good enough, or we're not sure, or so I think this is the biggest problem. And then we have like what we tend to call staff shortages. So we have a lot of it's very difficult to find enough nurses, especially, and in some disciplines it goes for doctors like family physicians. But hiring extra when they're not there, that's very difficult. So that costs a lot of money. And what we also see is that because the general vision is we have staff shortages, everybody is solving that problem.
Yeah.
And I always tend to say staff shortages are not a problem.
Yeah.
They are a solution disguised as a problem.
or it's a symptom of
because
other
yeah, but
problems.
because the solution is more staff.
Yeah, and for those
So
who are just listening, Arno did the finger quotes around quote unquote staff shortages. Right. I mean,
so yeah, and because it's actually, so they feel like they do not have enough staff, and then they shout to their managers, "We need more nurses, etc." And then there's all these vacancies, so people start to believing, "Oh, there's so many vacancies, we can't fill them. We have staff shortages."
Yeah.
But there's nobody who says, "Okay, why do you think you have not enough nurses?" And because that question would say, "Well, I'm working my ass off, and I'm so busy, and this patient didn't get her treatment, and that one is, and we have this waiting list, etc." So that we can reframe the problem to, we can't give all patients what they need. If we would frame the problem as we can't give all the patients what they need, then you do two things. First, it's about what they need. So you have to understand, is everything you're doing, is it actually what they need? Or are you doing things that they don't need? Today we had a very interesting article in the newspaper about a hospital that's having patients and family members of elderly people discuss whether they want a hip operation, because all the elderly people, they have a lot of times they fall, and when they fall, they tend to break their hip.
Right.
But if they're old, it appears that many of them, when you ask them, they have very different priorities than being mobile again, because often it's not possible anymore. So they don't want pain, and they want a high quality of life. So they went from 1% to 13% of the people avoiding an operation and just taking palliative care. So, and so that would be, so do what they need and compare the work we do to what patients need. And then we have we have to focus on helping patients. So the primary task is to have enough capacity to do what patients need. And then we can ask, okay, where does our capacity go? And then we come back to this circle with this 3 parts, like a pie, where we spend only 1/3 of our time on what patients need. And then we know, we don't have staff shortages. The problem is the cause of us not doing what patients need is we let them do the wrong things.
Right.
If we would have them just do what patients need and nothing else, we have enough patients and enough surgeons and enough physicians.
Yeah.
So,
Arno, you talk about the need for productivity improvement, and that, that relates to cost and efficiency and other factors. On the cover of your book, Lean Thinking in Healthcare, there's 4 phrases that seem to maybe represent true north. So let me ask that as a question. Do these things represent true north to you or the hospital you're working with? Those words and phrases are safe, compassionate, zero waste, no struggle. Is that your true north?
Yes, and of course it's a summary, because what would be in the middle of that is it would comprise the right care at the right time, at the right place for the right patient. But that's the content of the work. And what I see in healthcare is that there's an unbelievable passion and scientific curiosity, and all the energy in healthcare, if it comes to doctors and nurses, is about the content of the work. But we do all these things around them, or they have all these processes and systems around them that fail them on the other aspects. So that's why I selected these four words, because I think, well, safe, you can't go around it. If it's not safe, then you might don't want to do it at all. And then compassionate, because compassionate means that you're willing to take action to actually help somebody. I had a great, I don't know, it was a graphic this week on LinkedIn by somebody who made the difference of pitying, sympathy, empathy, and compassion.
Right.
And then it was in gradations to how much you care about the other person and how much you're willing to help them or take action to help them.
Right.
So that's where the compassion comes from. And the interesting thing with the word compassion is you can maybe put the word, if you take away the word com, then you get passionate.
Right.
And I think that's what you want from your nurses and physicians and for everybody around them, that they're passionate about the work they do, about the patients. And what people tend to forget is that passion comes from, of course, from the I think it was the bearing of the cross of Jesus, and it has to do with being willing to suffer to get to your goal. So when somebody says he's passionate about this, about something, they often mean, or especially when coaches on LinkedIn say it, they often mean, I like this work. But passion is not about liking the work. It's about willing to suffer to get to your end goal. If you want to see passion, go watch cycling. I don't know if you ever watched the Tour de France or something.
Just a little bit, yeah.
But these people, they're 6 hours on their bike, so that at the end they can be 1 second faster than anybody else.
Yeah.
So it has not, and maybe they like cycling, but I'm sure you don't like it if you're 6 hours on your bike on an average of 40 kilometers an hour. So that's also what I have in my head, and that is because when you analyze, maybe to take a step back to where we started with improvement, the Japanese have this word kaizen. You know it very well, since the name of your company, Kinexus, is inspired from it, I guess.
It is partly.
Yeah. So, and if you look at the characters of Kai and Zen, you see a whip, somebody whipping, and you see an altar with a sheep.
And it's whipping yourself, not whipping.
Yeah, it is whipping yourself. So it means that continuous improvement means self-discipline and sacrifice.
Yeah.
So it's not just the true north, but it is also the emotions and the human endeavor we need to get to that point. That's where I think then the book is about. So on the front of the book it says these four things, where we want to end up. We want it to be safe. We want it to be compassionate. We want zero waste, and we want no struggle. But to get there, we need this engine of willingness to suffer to make it better for other people. And this is where maybe that's why lean is so difficult, I guess.
I can see two sides of that. One, I mean, sure, the need to put the effort into improvement is important, and there's bound to be struggle in our attempts to improve. But when you think of the passion that healthcare providers have, what word would we use? We could say it's a calling, that they have a mission, that they start their career with enthusiasm, but then they end up suffering too much because of the waste, because of some of the different dynamics. People get worn down or burned out or worse, and I think that's a big part of what we need to try to help fix in healthcare. And then that leads to staff shortages when people say, I can't take it anymore, and they
burn out,
or they quit, or I think we need to try to figure out how to break some of those cycles and
Yeah,
engage
exactly.
people in trying to help fix that.
Yeah, exactly. I mean, they have. It's hard enough to help fragile people and to sometimes fail. I mean, and nothing you can do about it. I mean, people die and people get hurt in ways that we can no longer fix them. So yeah, I think that's fair to say. So
Mhm.
we need to have them use this passion for their patients and not to work through the mud that we put on them.
Right. And I think maybe we can talk a little bit more about, one element of Kaizen is engaging everybody in improvement every day. And I know that's something you focus on in the book. I think one thing that makes it difficult to translate some of this from Toyota, not the language, but just from one environment to another, is I think a lot of the context of Kaizen is built on top of a well-designed system. Like Toyota people will talk about the obligation of leaders to create a system in which people can succeed. Dr. Deming would talk about the role of executives in owning the system. And I think sometimes, while sure, the ideal is to engage everyone in improvement, I think sometimes I see or hear executives think that all they have to do is empower the frontline staff. And like, well, they could be they can tweak the existing system, and there can be benefit to that. But when and how do you say we need to really redesign the system, and that has to involve more than the frontline staff?
So you were asking me about this, when should we go about changing the system instead of modeling on the shop floor to maybe increase it a little bit? Well, I would say as an engineer, when I first met the healthcare system, I was already thinking we should change the system. The current system is perfectly designed for the current results.
Sure.
And that's why I, with this engineering mindset, I made the introduction a chapter of the book is about what I see in the current system that's keeping us from actually improving healthcare.
Yeah.
And that has to do with the silos. We already talked about it a bit, that everybody is doing his or her work within his or her department and discipline. And because we did science and improvement processes all to increase the content of the work. But we did hardly nothing to change the system that is supporting that work.
Yeah.
So I would say we need to completely redesign healthcare, where the most important thing is that we look at the needs of the patients, and we look at what type of processes and models we need to help them, and stop putting all those models in one system, which we currently have. Because the way we get paid is the same all throughout, whereas the way we provide care could be very different.
Mm-hmm.
There's a great book about it. It's called The Innovator's Prescription by Clay Christensen. And he made some points about the difference between diagnosis and standardized treatments, and maybe treatments for illnesses we don't know much about, or what to do with chronically ill.
Mm-hmm.
Should we have them keep coming to the hospital, or is it maybe better that we have some system that they can have at home? Those kind of things.
Yeah.
So at the system level, I think there's a lot to be done. But the problem is you can only do that if you understand how to change systems. And for this, you need to learn to change small systems first. So if we could help people on a smaller scale learn how to change in a multidisciplinary way and teach leaders how to manage multidisciplinary cooperation and improvement, then this will give us the skills and the competencies and maybe the way of thinking we need to solve ever larger problems.
Yeah. I mean, like, there's that human tendency to want to jump to solutions, and we can learn on a small scale maybe how that doesn't work. But there are, at a larger system level, again, those efforts to jump to solutions, if we don't fully understand the problem. I mean, the U.S. for decades has thrown around this phrase healthcare reform, and that means different things to different people. Are there efforts to try to redesign the system in the Netherlands or Belgium that you're aware of? Is that kind of a political question of, well, how do we reform the system?
Yes, for a large part, it's a political. The interesting thing is it's not necessarily a political question, but it's made political. So sure. What we see in healthcare is that people are doing each other's work. Like I told you, that the health insurers are trying to define and manage quality of healthcare, where they don't know much about how to treat patients. And the same goes the other way around, in the sense that if there's problems in healthcare, like staff shortages, everybody is looking up to the Minister of Healthcare. And the problem is sometimes he even listens, and then he starts to devise solutions for the problems that people say are his fault.
Yeah.
And this is where the problem is. People are thinking about who's responsible, and they mean whose fault is this? And they start telling him, you need to fix this because this is all terrible. And then he fixes it with solutions that don't work, and then we get this cycle. I call it the circle of continuous misery. It's in my book as well.
Yeah.
As part of this introductory chapter, and but it shouldn't be. The problem is, and the other problem is, we don't really look at the current condition to understand it. We look at it as just to judge it as horrible, but not to understand it. So, and as long as we don't understand what we are now doing and why that is not working, or why it is working in some instances, like I told you about the general practitioners in the Netherlands, which is working quite fine. So we need these people. They make all kind of I don't know, you call it economic treaties. They make long reports, and they say, okay, for the next year we agree that we will do this.
Yeah.
But it's all words. It says like we need to cooperate more, and we etc. 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 But
what's that?
There's no system or idea how. So the best thing for them is to have everybody in the system just join to understand the current condition, with the aim of just giving patients what they need. And if they want to say with the least amount of cost, that will be, if you just give them what they need and nothing else, that will be the lowest cost version of your system.
Sure.
But then they have to agree that they're all in it together, and that they need a plan that's understood from all perspectives. Because these health insurance companies, yes, they have the obligation to pay the least amount of money for my care, because that's why I pay him the premium. So and I want the premium to be low. So we ask things from people, and when they do what they're asked to do, then they're blamed for it.
Yeah.
So that's not helping. I'm not sure. Is it the same in the US?
Yeah. I mean, I think there's something consistent in the human condition there of reacting to symptoms, jumping to solutions, expecting other people to solve it. You make me think of a really helpful idea that, Toyota people like Pascal Dennis have taught me, the difference between what they would call a big, vague concern and a well-defined problem statement. So you used a phrase, or we could just say something like, a big, vague concern would be something like, our healthcare system sucks. Okay, well, how specifically, how do we define that, and how do we define a measurable gap? Or it could be, everybody hates working here and they're all leaving. Okay, but that's a big, vague concern. We need to define the problem. We need to understand causes. We need to understand more detail of the current condition, as you're describing, and I know as you teach others. So, that disciplined problem solving process, even at a smaller scale, yet alone a bigger scale, that takes more time, but I think that's the only chance we have to actually be effective. It seems faster to jump to a solution and jump into action. And then if it's not effective, well, then we're either right back where we started or we've made things worse.
Yes. And there's another thing which I almost forgot because I'm so used to it, which the lean thinkers are, or companies like Toyota are, that we need to start to understand the direction. That's why on the front of my book is this true north, because we often forget about it. And if you don't have a true north, then you automatically get some vague problem statement. Whereas if you know that it's need to be a gap between something where you want to be or need to be and what you currently have, then you will start seeing, and then the clutter will disappear as well. Because I see in the Netherlands and some examples I saw elsewhere that we tend in healthcare, and maybe it's the human condition as well, as like you said, but we improve away from something. So we try to improve away from the current situation, which we don't like. But if everybody is moving away in a different direction, then the status quo remains.
Right. Or what? So we need to understand what we're moving to. What's the ideal? Exactly. That's an important part of the problem solving process. Define the ideal state. Right.
Yeah. Exactly. Yes. And I think that we should learn to start there. So. Yeah.
That's a great point. Not just what are we moving from, but what are we moving to?
Yeah. So that's
So one other thing I wanted to ask you, and again, we're joined by Arnaud Aurelio. His new book is Lean Thinking in Healthcare. We talk about the need to look at our work, to understand the current state, and to make things better. You also talk about and write about learning from the best. So what's the right role for that? Does that mean learning from the best hospitals or the best whatever?
Well, learning from the best. Luckily, it's not the first chapter. It's chapter 10, I think. So it's somewhere at the end of the book. And that's because learning from other people, I think in healthcare, they really try to, and they like to, but it has two problems. That first of all, they tend to start learning from other people by brainstorm or by visiting somebody before they understand their own situation and their own problem. And they haven't yet decided where they want to go. And that means that if you then go look at somebody else, you automatically will refute like almost everything you see, because it won't work where you're at.
Right.
For all kind of reasons. So they're jumping to solutions without being aware of it. They're jumping to the solutions of the other person. And then, of course, even if they like them, it's very difficult to implement them because they have no connection to their own problems.
Right. They're trying to copy.
A lot of cases. And then the other thing is they tend to go learn from the content of the work. So they go to learn from other. Let's say I'm a surgeon, I'm going to learn from other surgeons. I mean, surgeons go to surgeon conferences. which narrows down the amount of possible solutions extremely. Because then somebody who has the same job as you has already need to have the same problem, which they assume they do. And then if he solved it, I can solve it as well.
Yeah.
And if somebody is not a surgeon, maybe he solved it, but it can't be for me because he's not a surgeon. So if you learn, I feel that if you learn from the best, it's then learn from people who know how to solve problems. Or how to lead, because that's universal.
Yes.
So it's way better to invest in what you call meta skills.
Yeah.
New ways to solve your problems. And or if you can't find a good solution, I mean, if you understand your problem, then ask yourself, who solved this problem already? And then be blind for what kind of work they do. I mean, if you want to know how to safely change some information at the other end of the world, and then it will be automatically the same at this end of the world without anybody can have access, go to a bank. So if you want to design a EHR, ask banks how they make sure that your privacy and your bank account are guaranteed, despite the fact that you go to Singapore to get cash out of the machine.
Yeah.
I mean, I think that it was already in the 90s, or maybe the end of the 80s, that we were able to do this automatically world around.
Yeah.
And in healthcare, we're still, I think we have last year, we eliminated the fax machines from the hospital. So
wow, congratulations. That's
so yeah. So learning from the best, preferably learn from their ability to solve problems and from their leadership. And the best way to learn is don't go to another hospital. Because the problem with that is that you see all their solutions and you understand them. I used to organize study missions to the US, actually.
Right.
And we went to Seattle and with, I think, about 40 people from healthcare. And especially the physicians, they went on the tour because we were going to visit hospitals, like at Virginia Mason. But where they learned the most was at Boeing, because they didn't have that frame of reference. So they were completely, it's like going on a holiday. If you go to a new country, you can't be other than open to all the new experiences, because you don't have a reference. So they learned at Boeing that maybe building an airplane in 10 days and then have the client fly it themselves from your factory to the other side of the world, while you have put 300,000 different pieces together to get this plane, this might be actually also quite complex.
Yeah.
And if they can standardize their processes and they are able to manage quality and they are able to do it in a safe way and make the plane flow, then why can't a hospital?
Yeah.
So that's where they learned the most.
Yeah.
So in a sense, from the best in doing this extremely logistically complex process.
Yeah. Well, thank you for sharing that, Arno. Thought-provoking and really insightful. So I want to thank you for being here again today. Our guest has been Arno Aurelio. His website, and again, there will be links in the show notes here, leanthinkinginhealthcare.com, and the new book, Lean Thinking in Healthcare. Congratulations on getting that published and released. It's very exciting. So
thank you.
I hope it people check it out, and I hope it's well received. And needless to say, for those who are listening, the book is in English. So,
so, and if you by accident are Dutch speaking, the book is in Dutch as well, because I originally wrote it in Dutch and now translated myself. So,
well, I hope people will go check it out. So, Arno, thank you. It's great to talk to you again, and let's do this again sometime.
Yeah, thank you so much.